of course, you can start. In fact, though there are some challenges to start these patients on ARNI immediately when the patient is presented with at de novo, but the challenges would be the the maybe the use of inotropes in these patients or a renal dysfunction. But again, as soon as the patient is stabilized, the benefits of ARNI in these subgroup of patients who have presented with de novo heart failure with reduced ejection fraction is obviously there, and it should not be denied to them. So there is another trial where there after it was started shortly after hospitalization in acute decompensated heart failure in patients who were newly diagnosed, and they were seen for 10 weeks after randomization, and the endpoints they were seen was to see the tolerability as well as the patients who could maintain these dose. And it was found that they improved cardiac remodeling and the pump function more effectively as compared to ACE inhibitors ARB in patients with heart failure with reduced ejection fraction. It is practically important also to understand that there are various mechanisms that are going on in the heart during the heart failure. One of them is the activation of the RAS symptom, and another important would be the endothelin receptors antagonists, which this neprilysin inhibitors, which will again have a two-pronged effect on the remodeling as well as the peripheral effects these molecules produce in the patient with heart failure. They also are shown to reduce the high sensitivity anti-construction concentration in patients with heart failure who were admitted with de novo heart failure in patients with heart failure with reduced ejection fraction. So the transition study in brief, it was found that there should not be any delay in starting these patients. The initiation of other guideline directed therapy, this should also be started, and these patients, they should benefit by starting this. So the treatment algorithms now would look like something like this, that if the patient is in heart failure with reduced ejection fraction, the ARNI would be should be started early, along with the other state. And patients, if the patient is in fluid overload state, maybe loop diuretics can be given in the beginning. Once the fluid overload state or the CCF has been treated, then the patient should be started on MRAs along with beta blockers and ARNI. SGLT2 inhibitors should also be started. So the only constraint would be the comorbidities that will prevent these the drugs, and one should aim to achieve the optimal dose of these guideline-mediated therapy within 3 to 6 months of initial diagnosis of heart failure. So even in the European guidelines, ARNI is considered as a first-line therapy instead of ACE inhibitors in patients with heart failure with reduced ejection fraction.